very happy, Katja, that you're here. A long way, but
It's not that long.
a long way in research on donors. So we know each other for a long time. So really pleasure.
Yeah.
Up to you.
Thank you. Thank you very much for inviting me, for the opportunity to talk about our donor research in the Netherlands at Sanquin. So I'm going to present some of our studies that we've been doing, some of the results from our studies on how to mitigate donation-induced both iron and protein depletions. So it's related to both whole blood donors and plasma donors in the end. And I'm going to discuss mostly evidence from our FINEM and FORTE trials and also the recent supply project on plasma donations. There it goes. So before I start, I just want to briefly explain why we even do this research on, of course, quite a healthy population, blood donors. And of course, the main ethical principle underlying the need to investigate donor health is the first do no harm principle by Hippocrates. We want to make sure, of course, that these healthy individuals that donate their blood or their plasma without any compensation for that, except, of course, for, in most cases, some treats and something to eat and to drink afterwards, and also the travel costs that are reimbursed. We want to make sure that their voluntary contributions for healthcare don't come with negative effects for themselves and their health. And that's even more important because these donors, they really rely on the care and the knowledge also and the guidance from blood banks, and they really trust that the blood bank makes sure that they don't get harmed by their donation. And as long as the blood bank keeps telling them to come over and donate, they just simply trust that it's safe to do so. So we have to make sure that we really do the research to make sure that that is the case. Another principle that I think is important in the research that we do is that we also make sure that the material that they donate is optimally used. And with that, I don't mean only to make use of their donations for the transfusion and for making the medications, but also using the remainders of donations as much as possible for research that benefits the public. So what I'm going to discuss today is I'm going to start with some background information on donor iron management. So what happens when you donate whole blood and how to prevent iron deficiency and iron deficiency anemia. Then I'm going to dive a bit into our FINEM trial, which is a step-wedge randomized controlled trial, cluster randomized controlled trial on ferritin-guided donation intervals. Subsequently, I will talk about our FORTE trial, an RCT on donor iron supplementation. And then in the last part, I'm going to talk about plasma donor health protection, discussing what we did recently in the supply project. Yeah. So what happens when we donate? This picture gives an overview of how here on the left side, there is iron, of course, in your red blood cells, in your hemoglobin. And this is actually reused when the red blood cells are at the end of their lifespan and new red cells are being made. So you don't really lose that iron, but it's being used over and over again. And you also lose a daily amount of approximately 1 to 2 milligrams of iron that you then take up from your food, mostly by eating heme iron rich foods, which are the animal-based products. And then a bit less also in non-heme iron, which is in more plant-based products. And then you also have an iron store that's mainly in your liver, but also in other organs that is measured by measuring ferritin levels. And I often compare this to that hemoglobin is basically the amount of cash that you have in your wallet. So when you donate, you spend your cash that you have in your wallet, and then you need your bank account, your iron store, or what's measured with ferritin levels, to make sure that you replenish the amount of hemoglobin or your cash in your wallet. And that's basically where the problem comes, because it's quite a lot of cash that you spend with one donation. So you lose approximately 250 milligrams with one donation. And of course, that's a lot more than the average 1 to 2 milligrams that you lose every day. So if that happens, you have to then make sure that you take up more iron from your food, approximately 3 to 4 milligrams per day maximally. And also that iron is released from your store so that you can replenish the lost hemoglobin in your blood. But from what has been calculated before, or what has been studied before, it takes approximately 62.5 days if you optimally take up the iron and also eat a lot of iron from your food to make up for the loss of iron with one donation. So that's 9 weeks. And actually that seems rather optimistic if we look at the actual data from previous studies that have been done looking into ferritin levels after one donations, which show that it takes even more than 6 months in total to get back to pre-donation levels.
That's presumably some of a normal person, a vegetarian or vegan, at higher risk.
Yeah, they don't eat any animal-based products, of course, so they take up much less iron, and then it takes even longer. Yeah. And most of those studies, at least the one that was done in the Netherlands, was done only on healthy male donors, pretty young as well, between 30 and 50. So it doesn't say anything about females, premenopausal women in particular. So yeah, that is a most optimistic calculation. Yeah. Yeah, so regarding that, here you see on the right side of this graph the amount of iron that's lost with one donation relative to the total amount of iron in premenopausal females. So it's about 61% of their total amount that they lose. Almost half still for premenopausal females, and for males is still more than a quarter of their total amount of iron that they lose with just one donation. And here's a study that I briefly discussed before. So this is the study with the 50 male donors that were young. They made one donation here at baseline, and then they were followed up with repeated measurements of hemoglobin. As you can see here, this red line indicates the 56-day donation interval, and hemoglobin levels were more or less back to their pre-donation levels at that point. But here, when you look at the ferritin levels, you can see that it's actually at their lowest point after 56 days. And they were followed up for 6 months. And even at that point, they were still not back to their original pre-donation levels. So it takes a lot of time to get that bank account up and running again. Then this figure here shows some analysis that we've done in our donor insight studies. This was a study that was done about 10 years ago already. So before we implemented ferritin measurements as a policy. And what you can see here is that on the x-axis, you see the numbers of whole blood donations that these donors made here relative to their hemoglobin levels. And as you can see, it's quite stable. So with a larger history of donations, they do not seem to have declining hemoglobin levels, which probably is because they are selected. They are measured every time they donate. So if it becomes too low, then they stop donating or they get deferred. But if you then look at the iron stores or ferritin levels, you can see clearly that with increasing numbers of donations, these ferritin levels significantly drop in all the groups. And what we also saw was that when we looked at those with iron deficiency at the point of their donation, when they returned afterwards, and they mostly returned after approximately 3 to 4 months, then they had a 10 to 20-fold increased risk of having a too low hemoglobin at that point to be eligible to donate. So these low ferritin levels indeed seem to hamper their recovery from the previous donation. Now, this is some work that actually Manueli and I have done before in the BEST Collaborative, where we collected information from I believe it was approximately 35 different blood organizations all over the world in terms of what kind of policies they had in place and also their hemoglobin deferral rates. And we then linked those data to see if certain policy aspects were related to the number of or the actual rates of low hemoglobin deferrals. And what you can see here is that longer minimum donation intervals were associated with lower hemoglobin deferral rates. And also iron supplementation, when that's directly prescribed or provided by the blood service, is also, at least for women, significantly associated with low hemoglobin deferral rates. And of course, you can never really compare one blood service to the other one because there's many things that differ also in terms of the populations that are studied. But these results are in line, of course, with the randomized data from, for instance, the interval trial, where you could also see that ferritin levels and hemoglobin levels are lower with higher intensity donations, and also with the trial that was published in JAMA about iron supplementation that is effective to more faster recover from a previous donation. So what we recently did, and this one is not published yet, I'm going to move the bar again so that you can actually see.
Disappear for you.
Oh yeah, that's even
I can
better.
control
Even
it, yeah.
better. So we recently, within the EBA donor studies working group, we did a comparison of policies in 4 different countries in Europe, and then including England as also European. And as you can see, the policy that is in place here is actually, so here in the UK is actually the most simple one, with the copper sulfate test and then the subsequent hemoglobin measurement if it's failing. And then in Finland, they provide iron supplements to donors that are considered at high risk of iron deficiency. So they don't do any measurements, not any ferritin measurements. They do measure, of course, hemoglobin levels. But they just simply provide iron supplements to donors that are either young female donors or that have donated more frequently. In the Netherlands, we have a different policy where we don't provide any iron supplements, but we do measure ferritin since 2017, and I will get into more details about that later. And that's measured every 5th donation, and if ferritin levels are too low, then donors also get a long-term deferral. And then in Denmark, they actually have the combination. So we have a policy without any real iron focused in England and Finland with iron supplements, we with the ferritin guided deferrals. And then in Denmark, they do ferritin guided iron supplementation. So they do measure ferritin, and if it's too low, they send iron supplements by post to their donors. And actually, it's quite a complicated strategy, so I'll not dive into all the details. Yes. And this actually shows the hemoglobin deferral rates on top for the repeat donors, male and female, for the different countries, and also average hemoglobin levels. And of course, because of the copper sulfate test here in England, that could not be added to the figure below. But as you can see, the hemoglobin deferral rates are pretty similar among the 3 countries that do some kind of iron monitoring or iron management. But in the UK, the rates are much higher than in Denmark, the Netherlands, and Finland. So that's pretty interesting, I think. Of course, the probably most important question here is, do these low iron stores also have a health impact? So do actually these donors feel less healthy, or do they experience any symptoms or health problems because of their low iron levels? And this is something that is, quite a bit under debate still. You see some data that seems to show that there are some symptoms related, but also some very comforting studies. And I think the healthy donor effect is one issue that doesn't really help to answer this question. So clearly in interval, it was shown that with higher donation frequencies, there were more symptoms in donors, but this was not mediated by hemoglobin and ferritin levels. It doesn't prove that having low ferritin levels is really bad for your health. We did a systematic review a couple of years ago where we've shown that restless leg syndrome and also pica is possibly related to iron depletion in female donors. Then there's also contradictory findings from several studies that were done regarding birth weight of babies born from women that were iron depleted because of donations. There's also some studies that were done on long-term effects of blood donation, and those are mostly focusing on the potential protective effects of iron depletion, because too much iron is, of course, potentially toxic. So against cardiovascular disease and cancer. And also those results were very inconclusive, so we cannot really say that it's either healthy or either bad. And then there's also no evidence from our recent analysis on several studies that we've done in the Netherlands, where we actually tried to investigate whether non-anemic iron deficiency was related with symptoms. We did find an association with fatigue in men only, but we've also looked into cognitive effects and fatigue in women, of course, and restless legs and pica, and we could not find any associations there. So it could also be a chance finding. So to sum this part all up, so what happens when we donate? Clearly, iron stores are depleted, and particularly in male donors. You can also see that in the figure on the left, where we did repeated ferritin measurements in new donors, and you can clearly see on the left side, in men, they start off with higher ferritin levels, and therefore they also have more opportunity to go down quite a bit. The recovery of iron levels is a really slow process. These iron deficient donors then have a 10 to 20-fold risk of subsequent low hemoglobin levels. But apart from hampered hemoglobin recovery, it's uncertain if the iron depletion really has health effects. So I'm going into the FINDEM study now, the stepwise randomized controlled trial on ferritin-guided donation intervals. This was basically the policy that Sanquin had in place before implementing these ferritin-guided donation intervals. So up until 2017, there was only a hemoglobin measurement that was done in donors and on site. So if it's too low, they get deferred, and if it's okay, then they can continue to donate. But despite this, we saw that the ferritin levels went down a lot, as I've shown you before. So because of that, Sanquin decided to implement a ferritin policy in 2017. And we basically started proposing to do that as a trial, comparing within the donor population a group where we were measuring ferritin with some extended donation intervals to a group where that wasn't the case, and then look what the results are. But they were in quite a hurry because of the iron depletion and the concerns about that, and even some donors that came with really lots of evidence on studies that were done in literature showing that you're depleting our iron stores and you really need to do something about that. So there was a bit of a hurry of implementing something. So then in 2017, they said, we cannot wait for a trial. We simply have to start the policy and do something and not wait for another 4 years or even longer before the study is done and we can decide on what to do. So the policy was then designed as measuring every 5th donation, the ferritin level in donors. And this is tested from the sampling pouch. So the test is done in the lab after the donation, but the sample is taken just before. And then when they are iron deficient, so they have levels below 15 nanograms per milliliter, they are deferred for 12 months. And if they are between 15 and 30, then they are deferred for 6 months to make sure that they do not return with too low or iron deficiency at their next donation. And above 30 nanograms per milliliter, they can simply keep on donating. So because they said we are going to do this, implement this policy, and we have to start as soon as possible, we talked with people from the blood bank and we said, well, looking at our data from our studies before, it clearly will have a big effect on your donor availability if you're going to implement this policy in the entire country at once. So why don't you do this in a stepwise fashion, start with somewhere small and then spread it over the country until it's implemented all over the country. And if we then randomize the order in which you implement this policy in the different centers all across the Netherlands, then we can also evaluate the effects in a methodologically sound way. So they agreed to that. They really wanted to make sure, of course, that they could also break a bit if it would be a bit too impactful, and they did. And that's what we did. So here you can see that there were originally 4 different groups that the donation centers were randomized to. And because of the high impact it seemed to have right at the start of implementation, The groups were even halved, so the bigger ones, to make sure that the steps were a bit smaller because of the very quick decrease in donor availability as a result of this policy. So with the implementation, you can then, of course, see these two wedges of intervention and control groups. So you have an increasing intervention group, of course, with this increase of implemented sites across the Netherlands, and a decreasing control group. And we then added some measurement rounds at the beginning. So before the policy was implemented, we did a baseline measurement where we measured ferritin in archived samples of the donations afterwards. So they did not have an effect, those measurements, on the donor or on their donations afterwards. And then we did the same thing at mid-implementation, where half of the population had this policy implemented and the other half hadn't yet. And then at full implementation, and because, of course, the long duration of the deferral, we expected also a longer term until the results will become clear. So we did another implementation, full implementation measurements a year after it was fully implemented. And we also did at those cross-sections questionnaire in all the blood centers across the Netherlands to get an idea of the symptoms that they might experience. Then here are some of the results. So as you can see, we clearly have a big drop, mostly in iron deficiency and also in low hemoglobin deferral rates, the percentages that you see here. So the orange bars are the percentages of iron deficiency. At the beginning of, or prior to the implementation of the policy, this was 26% of the premenopausal female population, and this dropped with the implementation of the policy to approximately 10%. And for both postmenopausal females and male donors, it dropped from 22 and 24% to 5%. So it's a really big effect. And I think that the difference between the premenopausal females and also the postmenopausal females and men is mostly due to the fact that, of course, the premenopausal females, they still keep on losing blood with their menstruations every month. So that's probably why they have a somewhat more remaining iron deficiency in that population. And then looking at the low hemoglobin deferral rates, this also went down quite drastically. So in the premenopausal females, from 8% to 5.4%. Postmenopausal females, they started off with 4.7% and 2.3% in the end. And in male donors, it went down from 3.5% to 0.8%. So there's hardly any low hemoglobin deferrals left in that population now. Here you see the more continuous outcomes. So you can also clearly see here that if you look at ferritin levels in male donors, postmenopausal females and premenopausal females, they also significantly increase over time since implementation. And a bit less clearly, but also the same is the case for hemoglobin levels. Unfortunately, donor return rates went down, which is, of course, also not really surprising because you lose them for quite some time, and that might also impact their motivation. And at the same time, all the donors received a letter before the policy was implemented in their donation center, telling them that Sanquin was going to implement the policy in their center because of donation-related iron depletion. And of course, that might also increase their awareness of the fact that they lose so much iron with their donations that it might not be that healthy. So that might also be a demotivating effect. So not only the deferrals, but simply the fact that they get this information. The more secondary outcomes were, of course, the health-related questionnaire data. So we're looking into cognitive functioning, and we did not really test their cognitive functions, but it was a questionnaire designed mainly to self-report if, for instance, they forget their keys more often, things like that. So it's not the most sensitive questionnaire, but yeah, and unfortunately, we don't see any results on that. We also did a questionnaire to ask them about fatigue. Also no results on that. And then the SF36, it was, if I recall correctly, on mental health and physical health. Also no effects there, unfortunately. And then the same for pica. And then we saw some surprisingly increased mentioning of restless leg syndrome. But then we found out that in that letter that I just told you about, that the donors received before the implementation of the policy, there was also mentioning of, for example, restless legs could be a symptom related to iron deficiency. So we think that probably the increased reporting of restless leg syndrome in the donors was likely due to that. Yeah.
I just don't know what pica means.
Oh, it's eating of non-nutritive substances. So like eating crayons or ice cubes
Okay.
or raw pasta, things like that. Well, raw pasta is nutritive still, but
Yeah.
yeah, and it's linked to iron deficiency in some studies. So yeah, but we couldn't find any of this. So to conclude, these ferritin-guided donation intervals are clearly associated with improved ferritin levels, less iron deficiency, also less hemoglobin deferrals and better hemoglobin levels. But they had a negative impact on donor return, and also this effect on restless leg syndrome, which is probably due to more awareness. But we couldn't find any association with other iron deficiency related symptoms. And most importantly, actually, so it clearly helps to maintain iron and hemoglobin levels, but it doesn't necessarily help to improve their health. And a really important thing is that it really required a lot of effort from the blood service to make sure that they still were able to maintain the blood supply. So they had to recruit many more donors and also had to put in extra efforts to retain the donors. There really was quite some stress at certain points during the implementation of this policy. And now with full implementation, we look at approximately 40,000 donors that are unavailable at any point in time because of a ferritin deferral. And the Netherlands is, of course, a bit smaller here than here the UK. So our total population of donors is approximately 300,000 of whole blood donors. So we're looking at 10 to 15% of the actual whole blood donor population not being available to donate at any point in time. So it has quite a big impact. They're managing it quite well now, but it has been quite a struggle. So that's really good to keep in mind if you would ever consider implementing such a policy. And that's sort of automatically also brings us to the next trial that we started. So when this policy with the ferritin-guided donation intervals was implemented, there was also suddenly an increased interest in iron supplementation to help these donors recover faster from their low iron stores. And because of that, we also proposed to do an iron supplementation trial to get more evidence on how this could work in the Netherlands. So to briefly sum up the literature that was available before we started, it has been shown, of course, in various studies before that iron supplementation helps to increase hemoglobin and ferritin levels after donation, especially in risk groups, and because also donors with low ferritin levels, they take up the iron faster. So it helps to replenish that even better than in donors that have higher ferritin levels. That was also shown in the study by Joseph Kiss. It's more effective to directly provide donors with iron supplements than to advise them to take them themselves, which of course makes sense because it has mostly to do with compliance. There's quite a lot of side effects, although they are not reported that much in most of the studies. But when they are, then there definitely are some side effects, mostly gastrointestinal effects. The compliance, of course, is important. Low dosages seem similarly effective as higher dosages, and it's a bit uncertain whether or not it's really beneficial also for perceived health. So this is the design of our Forte trial. So we basically invited donors to participate in the study for whom ferritin was measured in their next donation. So donors making a 5th donation were invited to participate. And then when the ferritin result would come in from the lab, we would include them into the trial if it's too low. So if it's below 30 micrograms per liter. Which also is in line, of course, with this policy of extending their donation interval to 6 months or even 12 months. So they did per definition not have any subsequent donations in the next 12 months, which was also ideal for the trial. Then we were randomizing them to either a placebo, 30 micrograms of iron or 60 micrograms of iron. And they were instructed to either take the supplement every day or every alternate day, because that is hypothesized to help increase the uptake of iron, because after you've taken a tablet of iron, your hepcidin goes up, which then hampers the uptake of iron with your next supplement. And on the side, we also did more qualitative work because we wanted to know whether or not donors would actually be willing to take iron supplements. So what are their ideas about this? And also in the blood bank, so the blood collection staff and the donor physicians. So we did focus group interviews with donors, with blood collection staff, and with donor physicians as separate groups, mostly to get an input on their perceptions. And then as a follow-up, we also did an online donor survey to get an idea of the knowledge on iron donation-related iron depletion and also iron supplementation from the donors, their perceptions, and we also did that in various countries, or still ongoing actually, to see if this differs between countries. So based on those 40 focus groups, we saw that the main motivators for donors to take iron supplements would be to prevent a deferral from their iron due to iron deficiency, so to be able to donate again faster, but also if it could help them to reduce iron deficiency related symptoms, of course. They would not be so willing if they would experience gastrointestinal side effects, of course. And some also just indicated, I am not very willing to take any dietary supplements in general, so the same holds for iron supplements. And donors would expect that the donor physicians would really guide them through the process, also that additional ferritin measurements would be done to see if there's an improvement in the iron stores after the supplementation. So they really wanted this involvement of the blood bank and the donor physicians. And the donors and the donor physicians were actually more positive towards iron supplementation than the blood collection staff, which seemed to also be related a bit to their lack of knowledge on what actually happens physically after a donation, the amount of iron that is lost. And they feel a bit more that it would force donors to donate more often if we provide them with iron supplements, which of course is not the intention with this, and donors do not seem to see it that way. But it's the donor collection staff that seems to have this concern mostly. Then the survey, this part is still ongoing. So we did a survey internationally to assess donor perceptions and knowledge. And we did that in different countries to also take into account the different policies that are in place and how that might affect these perceptions and also the knowledge levels. So there's one part that actually is a survey for the blood establishments themselves to complete on what policies they have in place. And we've have the data from 12 different blood services for that now. And then the subsequent part is for them to actually send surveys out to their donors to get an idea of their knowledge and awareness of donation-related iron loss, and also about the iron management policies that are in place or that could be implemented, and what they think of these different policies and whatever they would prefer. And we've worked out the results of these surveys for Finland and the Netherlands. So as I've shown before, in Finland, they have this iron supplementation without any measurement of ferritin. And in the Netherlands, there's ferritin-guided donation intervals without iron supplementation. The donors in Finland seem to know a bit more, or seem to answer the questions about hemoglobin and ferritin a bit more correctly than those in the Netherlands. In the Netherlands, the Dutch donors, they found involvement of physicians more important, but that's probably also because we have them at the locations where the blood is being collected, which is not the case in Finland, like here. And Finnish donors, they seem to prefer iron supplementation most, probably because it's implemented there already. While Dutch donors are, they sort of scored everything a bit similarly. So they did not have a really outspoken preference for any of the options that were provided. But the first option that was mentioned, or at least most often, was dietary advice, secondly deferral, and only on the third place, iron supplementation. And actually, both in Finland and in the Netherlands, stopping to donate because of iron deficiency is the least preferred option in general, very clearly. So then back to the Forte trial design. So I've already shown you the iron supplementation that they were randomized to. They received this invitation to participate 21 days before the donation. Then at baseline, they signed informed consent. Some of them got excluded if they had sufficient ferritin levels. And then we randomized the low ferritin ones. And they were followed up 56 days after their donation. So we invited them back to the center to measure their ferritin and hemoglobin levels, and also to do some questionnaires. And this was also repeated then at 122 days, which is the minimum donation intervals for female donors in the Netherlands, and after 6 months to see how fast they recover from that donation with and without the iron supplementation. And these are some of our, well, quite preliminary results. As you can see here on the left side, I think the time point 56 days after the donation is the most important one, because of course that's the classic minimum donation interval, and we really want to give them these iron supplements to increase the speed of recovery. So that's why we mostly look at that time point. And as you can see with the placebo, the red bars, they indicate the hemoglobin, low hemoglobin deferral rates or levels. And as you can see here, the ones that received only a placebo had a really high risk of having low hemoglobin levels at that point. And also dark blue is iron deficiency. Almost half of the donors had iron deficiency after a placebo. And here, as you can see, with the 30 milligrams, it's much less also for both for iron deficiency and for low hemoglobin. And the same with the 60 milligram, or a bit stronger even. You also see here that there's much less iron deficiency and also much less low hemoglobin levels. And actually the difference between the daily and the alternate day supplementation is hardly visible. So we do see somewhat stronger effect for the 60 milligrams of iron, but probably because it's already quite a low dose, even the 60 milligrams, this hepcidin response is maybe not that big, and therefore the alternate day supplementation doesn't really do much else than the daily one. So what we conclude from the different studies around Forte is that donors generally seem to be open towards iron supplementation. Daily iron supplementation, but supplementation in general really helps to increase the speed of recovery. The compliance was overall good. We've measured that in various ways, and actually they were pretty good at that. We saw limited or hardly any effects on symptoms and also on side effects. We both asked about symptoms related to iron deficiency as well as gastrointestinal effects. So it might be offered as a potential alternative to ferritin-guided deferrals in donors. So if they prefer to come back sooner, then they might be offered these iron supplements in the future. But this is something that we still need to discuss in detail with the blood service. But that might be the next step. And then for the remaining short amount of time, I'll go quickly through this part. We're also actually have an increasing interest in plasma donor health protection, because this is a subject that we haven't been focusing on a lot before. And I know that's also something that's increasingly, well, of course, because it's recently started only here to also collect plasma from donors. So we recently finished up the supply project. This was a EU for Health program co-funded project led by the European Blood Alliance, and it ran from September 22 to February 24, with the aim to increase and strengthen plasma collections all across Europe, and well, to provide a more stable collection. And I was involved in the work package related to plasma donor protection, and we had the objective to facilitate evidence-based plasma donor protection practices. And of course, it was a short project, so we could not run a trial or do any large studies. But the aims that we had within this work package was to do an inventory of the existing plasma donor protection practices across Europe, to evaluate the available evidence on plasma donation and health, and mostly on plasma donation frequencies and health effects. A third task was to design a support tool on standardized donor vigilance data to be able to collect the same data across Europe. And then in the end, to develop recommendations based on all the previous steps. So the first step was to do this inventory. We've led that from Sanquin. We did a survey across the different blood services across Europe based on our previous IPFA survey to cover the plasma collection and donor selection and donation procedures, and also how they collect vigilance data and how they register all the donations. We got 18 responses from 17 different countries in Europe. And we saw some very clear differences, mostly in donation frequency. So the annual limits for plasma donations in Luxembourg are really low. Only 12 donations are made there every year. And then in Germany, it's up to 60 donations per year. We in the Netherlands collect a maximum of 26. So that's approximately every 2 weeks. And then in the US, they even collect twice a week plasma donations. So that's very, very different. Selection criteria are mostly the same. The donation procedures are very different as well. So some used very small volumes, of course, for instance, to collect some larger volumes. Some are sex, weight, and height based. Some are just standard volumes. And also the machinery that's used is very different. The amounts of citrates that are used are varying a lot. Flow rates are different. So there's many aspects that might impact health that we don't know much about, but that are different across countries and even sometimes within countries. And then the testing, well, all of the questions services were testing total protein levels, but not everyone is testing, for instance, IgG levels, irregular antibodies, ferritin levels, HLA, and cell counts. So there's quite a lot of differences that might be good to overcome. The second task was led by our colleagues in Belgium to evaluate the existing evidence on plasma donations. And they first started doing that by making a scoping review and an evidence gap map. So this is basically just to get an idea of what evidence or what papers exist on certain topics within this field of donor health and plasma donor protection. And you can clearly see that the more blocks are in a certain area, the more evidence is available on that certain topic. And clearly there are mostly gaps in plasma donation frequencies, for instance, in relation to adverse events and health effects, and also donation volumes and total time in donation programs. So then subsequently, we also did a systematic review, and this was focused more specifically on the question whether what the impact of plasmapheresis frequencies are on donor health and safety. And we could only include 4 observational studies, 1 finalized randomized trial, and then also a non-randomized trial. And we found an ongoing RCT in Norway. But these were basically all the studies that have been published or that have been done in general about this topic, which is not that much. And the RCT was also done in Belgium before, and it clearly shows when you, so I think it is somewhere on the slide, were approximately 60 donors, if I recall correctly, randomized to 4 different frequencies, and also a placebo group not donating plasma. And you can clearly see, going from left to right in this figure, that IgG levels, they drop a lot with high frequency donations. And this was, so the very high frequency was twice every week. I'm not entirely sure if that's correct, if it wasn't every 2 weeks, but I can look that up. And the high frequency also was associated with a drop in IgG levels, and this was 3 times per month. Yeah, indeed, there were 63 donors included in the study, and it's a well-designed study, but it's also small. It only included male donors, so it doesn't say anything about female donors again. And it was not really designed to assess hard endpoints. It did result in few adverse events, no effects on blood pressure or body composition, or exercise performance. They even measured VO2 max. But they did find some results on the IgG levels and also on hemoglobin and ferritin levels in a very high frequency group. The STIPLA study is a non-randomized study that was done before in a much larger group, but unfortunately this study did not have a control group, and it did show quite a large dropout, which is partly due to low IgG levels, so they do seem to decrease. And they concluded that intensive donations were safe when monitored, when the IgG levels are monitored in the donors. We weren't sure to really agree to this message because of the large dropout, which was actually due to the IgG levels. And they saw a smaller incidence of severe cardiovascular diseases in the population, but that's probably just a healthy donor effect, as we see in many other studies as well. This is a study that was done in Norway, so this is the still ongoing trial. And in Norway, they also randomized, unfortunately, only men. It's a bit larger group, so it's 120 men that were randomized to once every 2 weeks of plasma donations, three times over 2 weeks. And then the control group was a whole blood donation. So it's quite an unusual control group, I would say. But then they followed up on the total serum proteins on the left side of this graph, and you can clearly see it going down a lot with the high frequency plasma donations. And on the right side, you can also see for the IgG levels, they also went down a bit, a lot for the high frequency, but also somewhat for the regular frequency donations. And then there were 2 other interesting studies that were published after the systematic review. They were actually published by PPTA. The first study showed effects of donation frequencies on US source plasma donors. And they did a general health questionnaire to assess whether or not donors with more frequent donations or that had been doing more frequent donations, whether they had a better reported physical and mental health in comparison to the less frequent donors. And they did not find any associations, and therefore they concluded that high-frequency donations are safe. But of course, you would actually expect that the high-frequency donors are the ones that are healthier to begin with because of this healthy donor effect, the selection effect. And they did not see that at all. So that might have leveled out something that actually might have been a negative effect. So we think that methodologically it's not the best study and not really something to conclude from that these donations are safe. And then another study that they published at the same time showed why do US source plasma donors stop donating? And here they questioned donors about their reasons to stop donating. The main reason that was mentioned was convenience. 69.1% of the donors indicated that as a reason to stop donating. And less frequently, they reported self-related health concerns that could, but also could not be related to their plasma donations, 45.5%. And their conclusion based on this is that this provides additional evidence that supports the safety of frequent plasma donations up to 104 donations per year. But of course, these 45.5%, we don't think that's negligible because it's still a lot. And of course, we don't know if it's related to the donations, but well, this type of research is of course not something that you could actually use to comfort donors and to make them see that it's really safe to donate that often. But they actually are using those papers to provide that message. So we have developed recommendations mostly to gather more evidence on the safety and health effects of different plasma donation frequencies. And I know you're preparing a trial here to investigate it in a larger setting and also in a very nice way. And we hope to be able to also do that in the Netherlands, so to also investigate the different plasma donation intensities and also volumes to see what the effects of that are on donor health. And until we have a lack of that evidence, we hope to keep the donation frequencies down to be able to protect the donors from having too large drops in their IgG and protein levels. And with that, I want to thank, of course, everyone that I've collaborated with, both in the Netherlands as internationally. And of course, the donors and the personnel and management at the Sanquin Blood Bank for all their help. And before I stop, I also wanted to briefly mention this, that we're going to organize the European Conference on Donor Health and Management in September 2025. So it's still quite far away, and we haven't been officially communicating this yet, but please save the date, because if these type of studies are of your interest, and we're going to discuss that in quite a lot of detail there as well. So this conference has actually taken place here in Cambridge in 2016. And it started once in the Netherlands 2 years before that. So we're happy to have it back in the Netherlands, and I hope to see many of you there as well. So with that, I'd like to conclude so that we have some time left for questions.
Thanks, Katja. Very, very interesting. So tour de force across ferritin, iron supplementation, and plasma. Question from colleagues online or on site.
We have some questions online, but we'll see
Okay.
if the audience on first.
Okay. Yeah.
I had a small question about these. So in the final file, apparently, you sent out letters to us saying we're doing this and this is. And so in our scratch file, there was like, I think, no letters sent, but there was kind of posters and the inside saying we're running this file. So do you think that, was there an option also to just not send people letters saying, oh, we're just implementing this? Is that a good ethical issue as well? Like, what if you reply to not? Because that might have been something else I said.
Yeah, I think it's more of an ethical issue, because it was the decision, of course, of the blood bank to do it like that, to inform the donors we're going to implement this policy. So your ferritin is going to be measured, because of course, before that, that was never done by Sanquin. So they had to be informed that this was going to be an additional measurement, and that it could also imply that they would not be able to donate for a really long period if it would be too low. So yeah, we had to deal with it.
Sorry, hearing the question, which I thought might be, so do you mind paraphrasing the question after just giving the answer?
Oh, sure. Yeah.
Really hear it, yeah.
Sure, yes, yeah. Yeah, so the question was indeed whether or not we had any saying in whether or not to give this letter to the donors, or to send a letter to the donors before the ferritin policy was implemented. Yeah.
Any other question from colleagues here? I have one maybe before going on. So you said that 40,000 extra donation need to be found from
Yeah, so
the
40.
voters. How did they manage that?
Yeah, so 40,000 donors indeed are available to donate at any point in time at the moment. Yeah, how do they manage it? They've been recruiting many more donors.
Okay.
And of course, at the same time, the demands for red blood cells, they keep on going down. So that helps a little bit. But yeah, it's mostly the recruitment, yeah, and getting an active donor population, because I think there were quite a lot of donors that were registered but not actively donating. And when this policy was implemented, they really had to make an effort to either get those donors coming back, or to get them out if they don't respond at all, because it's also a loss of energy, of course. Yeah.
So I'll take one of, thank you, question online. There are 3 questions from the same person, so I'll just start with the first one. This is our colleagues at the BTRU working in Oxford and London. They're interested in data-driven treatment practice. So do you know about any research that has been done looking at low iron women with Black African, Black Caribbean background? And attached to that question is, and if there are any genetic reasons why women from this background have low iron levels, too low to donate? And there's some research in this department, somebody is looking at that, particularly people on the African continent.
Yeah, no, that's an interesting question indeed. Do I need to repeat this question, by the way, or can they hear you or read it in the chat?
Yeah, good point.
I think they can read that in the chat.
Yeah, they can read it.
Okay, so the question is in the chat. So it's about African donors and whether or not there's any evidence on their genetic.
Black African and Black Caribbean.
Exactly. Yeah. Well, I know there's some evidence, but I also know that it's unknown whether it's a genetic thing or whether it's also related to their dietary habits, for instance, and other potential. But we know, of course, that hemoglobin levels and iron levels in general are lower in that population, so that makes them more prone to be deferred, unfortunately, because we also need those donors, of course. We're planning on doing a study into that actually, because we have access to a cohort in the Netherlands that's multi-ethnic. So we're hoping to find out, because I think there's a lack of evidence as to what causes this, to find out more about this when researching those individuals. Those are not donors in particular, it's a general population cohort, but we hope to find out more about this subject because I think we know too little. Yeah.
That's encouraging. Stephen, do you have a question? Then we'll go back online.
I was just wondering about the suitability of the genetic instruments like the SF36 questionnaire. Do you think it's measuring the correct construct in terms of validation?
Yeah, so the question is whether or not the SF36, for instance, is measuring the right construct for the donors. Yeah, I have to say I'm not entirely sure because it's not the most sensitive questionnaire. Mostly also for looking into changes. So it might be a good instrument to get an overview of a population and how they are divided in terms of general health. But if it really gets to pick up differences in donor health longitudinally, I'm not so sure. I do think you saw some declines in the interval population, right? Or
So we use that as well. But
yeah,
It's very small changes.
yeah, it's not the most sensitive questionnaire. I think it's a bit too broad, maybe. Yeah, it's not so specific. So yeah, it gives an idea, but not ideal, I guess. Yeah.
Yeah, and another question online. Or
Yeah, there are two more questions online. I'll just take the next one and then we'll go back to the room. So this is also from Lyndon from the other BTRU. Is there similar arm monitoring in the UK in addition to the fingerprint prick test before donating? Maybe that's for the UK-based researchers to answer.
Say again, sorry.
Is there similar arm monitoring in the UK in addition to the finger prick test?
No.
Mhm.
No. Oh, okay. That's a no, Linda. And yeah, any other questions in the room?
So maybe a bit more provocative question. So you showing that in the Forte trial, you're increasing hemoglobin level, improve ferritin, and then potentially, I guess you reduce the deferral, yeah.
Mhm.
But are we not, given the lack of information about iron and health, are we not treating just a biomarker more than anything
Yeah.
else? So there should
Yeah,
be.
that's a good question, and I agree that it seems to be a bit like that. I think we are in some way basically treating a biomarker, and I think it's mostly ferritin, and it helps to prevent, of course, also the low hemoglobin.
Yeah.
So I'm not sure if it really helps to better maintain donor health in terms of what they experience themselves. It might on the long term, but we don't know.
Yeah.
It's a tricky one. Yeah.
Is there evidence in, like, for example, women get, I'm not sure if this is correct, when women give birth, then that maybe consequences of iron deficiency, is that something that?
Yeah, one study said so, and then another study said the exact opposite.
Yeah.
So I showed the exact opposite. So I'm not so, yeah, it's very inconclusive. Yeah. That might also be due to the healthy donor effect, because you get the follow-up information from the donors that keep on donating. So you don't know what happens to the rest, of course.
There's a question about women giving birth. For those who, sorry, the microphone is so forward here. We need to either come closer or repeat the question. So there's one last question online. Is there educational materials for donors about the importance to restore iron level after donation in the Netherlands and the UK? These questions are coming from our colleagues who don't actually look like don't research donor health like we do. They look on the transfusion side. So that's the basis of a lot of these questions.
Yeah, no, that makes sense. There's not that much information that is provided to donors about what they can do themselves. I think that's mainly what's being asked about. And that was also because, well, Sanquin, at least before, did not actively want to get donors to take iron supplements, or not want to push them towards that. And we did a study before with dietary advice, which didn't seem to work. Also because it's probably might help a little bit, but the amount of iron that you lose with one donation is so much that it doesn't really seem to help, at least not in that study. So that was a reason also why in the blood services said, well, then we're not going to give them that advice because it doesn't help. I still think if donors really want to do something in themselves, that you could say, well, in theory, it could help to eat this and this, but they're not actively doing that. I don't know what's the case here in the UK.
David, you're a
No,
donor, we're
yeah,
a
so
donor.
pamphlet that says, if you have difficulties, phone this number, and that's basically what it says.
Okay.
What, can I ask about, oh, sorry.
No, sorry, I was saying that, like, I think maybe even though there's no official policy about educating neurons, it might be that specific blood centers have staff who might say like, oh, maybe if you try to eat this, maybe there might be, it is your quality to say, well, I know they found that there's some staff.
Yeah.
They have different practices, right, so I think it might be it.
Yeah, it could indeed be the case that some staff might give different advice than other staff, even though they're instructed to all do the same. And in practice, we know that it's not the case, of course, not always. Yeah, that's a good point.
I would want to ask about the IgG level. Does that have any significance? So are people getting more infections, or why was that so
Yeah,
important
that's-
with the plasma?
That's questionable
Yeah.
still. I know that they've been trying to investigate that in Denmark, where they have this scanner database, and they haven't been able to find any increased infections in donors
Okay.
with low IgG levels or with high frequency plasma donations. But then in Denmark, they also have really low frequencies in general of plasma donations, so they might not be able to actually pick it up if there's any effect. So as far as I know, there's not any data on that. Not that much at least. No.
Interesting, very interesting.
Any additional question that online or on site?
There's one here from
Maybe the final one?
patient
Yeah.
member. NHSBT, our blood service in England, has a couple of iron deficiency and iron and dietary. Certainly, I think representative. It's more information on than a question. It's
Okay.
reading is there. Thank you, Brenda, for that.
Thank you.
Excellent. So, well, thanks again, Katja. It was very,
Thank
very
you.
informative,
Mhm.
very interesting for us.
Good. Yeah.
And well, thanks again for attending.
Great, and thanks everyone online for coming.